get onto slide? I think it's over here. Slide. Okay, that's it. Well, thank you all for coming here, and it's an honor to see the room so full. As I look out over the room, there are a lot of my friends. Some of them, this being in Chicago, are my residents, and this is really our family that we've done so much to develop. And in fact, I'm saying that literally because my family is here, my son, daughter, and wife. So it's an honor that they can all get here because they're living all over the country right now. A lot of times when we give talks, we're nervous because we wonder how are people going to think about what we're doing. Is it going to be accepted or not accepted? But this talk, if I don't present it properly, it's not me that I'm talking about. It's all of you and the people who got you here. And that's why I'm not so nervous about the content of the talk. I'm just nervous will I present it dutifully to the people who built it up to this. So I'm going to just go through a few questions. And as Arun said, we all in pediatric plastic surgery have to diversify. We're not just skeletal surgeons, we're soft tissue surgeons. We really do the gamut of surgery on the child to help their wellness and self-image. So I'm going to focus on one particular question and then ask how do we take that question and make it something that is of merit to us in investigation. So begin with a clinical question, just tissue expansion for pediatric forehead reconstruction. It's not an easy problem. The forehead, giant nevi of the forehead, and whether you have a nevus, a hemangioma, complex scar revision, is difficult because your donor tissue is limited. You only have the forehead. There's the scalp above you, the eyebrows below you, the cheek below you. If you distort things, you're going to distort the eyes. So it's about as complicated an aesthetic unit as you can think of trying to work on. So just how did we look at that approach? So here is a child with about 2/3 of the forehead involved, part of the eyebrow. His scalp is involved, but his cheek is spared. Notice how the nevus does not go much below his lateral canthus of his eye. So that's a goal that we look for in terms of how much of that is involving below the lateral canthus. So this child we did about 25 years ago. We expanded the forehead we had, did a rotation flap like a sail flap and covered that in. And she had a slight loss, but that healed by secondary intention. This girl actually came to me about a year ago here in Chicago, and I just remembered her name this morning to try to get the 25-year follow-up, but unfortunately her photos were not captured, so otherwise I'd show you her 25-year follow-up. This is another young child. About half of the forehead is involved, partial eyebrow. The scalp is involved, and now it does go into the cheek below the lateral canthus. So in this case, we're going to have to expand the scalp, expand the forehead, and begin expansion of the tissues down to areas below the lateral canthus. Here now is 1/4 of the forehead. It goes to the temporal hairline, and it goes to the cheek below the lateral canthus. So here the thought being we've got to recruit forehead tissue, scalp tissue, and cheek tissue in order to take care of that. So that's where we put our expanders, and we're able to bring those tissues into one junction line. Families always ask, well, what kind of scars are we going to have from this? And we always say, well, there's, by definition, there has to be a scar where the tissues meet, but the goal is that your native tissue is meeting rather than tissues that don't look like part of your face. As we continue that, to continue the expansion, they will often have brow ptosis and skin redundancy because the tissues have been pulled from a new location. And so we always let the families know in these cases we have to come back and deal with that as a separate procedure. So we'll do a brow lift and take care of that redundancy. This is about as challenging a forehead lesion as you can get. It's about 90% of the forehead. It goes into about 2/3 of the scalp, so we have about 1/3 of the scalp left, and it takes up much of the cheek. So the question is, can we even do this with tissue expansion? So this was actually one of the first giant nevus cases I had when I finished my fellowship. We went on with tissue expansion. We were able to get the tissues from the neck up to above the lateral canthus. The forehead, of course, there wasn't enough tissue to do expansion, so we did that with a full-thickness skin graft from the abdominal region. And here's the child here. We were able to get the hair completely across. So this came up in our indications conference last week. Can you get 1/3 of the scalp to cover the rest of the scalp? And the answer is you're going to have very thin hair, but you can do it, and it's certainly an option if the children want to pursue that. So in conclusion, the majority of lesions extend beyond the forehead, so we have to do simultaneous expansion of the scalp and or cheek. If we're going to do rotation flaps, we have to do them with caution. As you saw with that sail flap, we had some distal necrosis that healed by secondary intention. Realize that brow ptosis is inherent in the expanded forehead flap reconstruction, so we saw it in about a quarter of our patients. So we want to minimize skin excision at the time of the expansion, let that tissue contract over the period of the year, and then excise less redundant tissue and do an elevation of that ptotic brow. And lagophthalmos is something the eyes may have a slightly different position in lid closure, but it's usually self-correcting. So that not to go through this algorithm completely, but just let's take a simple problem. Say you have a giant pigmented nevus. We know that we, say we have more than 25% of the forehead involved, and so if it is more than 25% of the forehead, based on how much is involved, we can think what we have to do. If it's greater than 70% of the forehead, it's going to be hard to get that 30% to replace. You might as well start thinking about tissue from somewhere else, whether it be an expanded full-thickness skin graft or if you want free tissue. Those are all options. If it is less than that, as we mentioned to you, then we want to look at such things as where it is relative to the lateral canthus, and we also want to look at where it is relative to the scalp. And based on what we told you, we can get an algorithm. Do we want to expand the scalp? Do we want to expand the cheek? And do we want to expand the forehead, or should we go to something more extra axial in tissue? So as we know, whenever we ask for tissue expansion, we ask what available tissues do we have to cover the defect? Where do we want the final scars to lie? There have to be scars. We have to let the family know that, because families think that because we're doing this, there are going to be no scars. And how can you minimize the tension when transferring the expanded tissue? That last question is not such an easy question, because as we know, a lot of the times we put in an expander, but the tissue that we need to get to the new place is not in the place where we want it. It's where the expander was. It's not where the lesion was. So let's look at the problems we have in tissue expansion. When we design a flap, we do it with the best of intention. We'll design the flaps around the area that we'd like to go to. In this particular case, there was a serial advancement. Here's where the flaps were. In the end, this all, because of the tension, broke down. And here's what you have. You basically have scars. You could have avoided tissue expansion and just put skin grafts on there. But that's the type of information we need to know, we need to plan on, and we need to let the family know these are our options. So how can we really ask that question? And that's where it becomes the investigative side. And some of my residents are here, and they'll be able to tell you more about what we're doing. Lindsay is here. She's really working on this in the lab extensively. But the question becomes, what comes first, the clinical question or the experiment to answer it? Because they go hand in hand. So we are looking at an application of finite element modeling to optimize the design of tissue expansion. We know that the mechanical forces will significantly impact the success of repair with tissue expansion. So how can we figure out, by putting isogeometric parameters, that what tissue stresses are going to best optimize the transfer of those tissues to where we need it? We, just going again, this was one of my residents who worked with me last year. We looked at all of the cases that I've done in tissue expansion. We looked at the different problems, and that's just been published. But you can see that expansion has inherent problems. We know that, and we have to tell the families that that doesn't mean the end of the transfer of tissues, but it means an alteration in the route we're going to have to take to get there. But I always tell families that we are going to get there. And so this is where this young man, Adrian Topole from Purdue University, has really been a superstar in terms of trying to help us to get finite element analysis to say what is going on with the stress and strains on those tissues. And we started with a study just looking at if we expanded tissues, if we advanced them parallel to versus perpendicular to the lines of relaxed skin tension, what would be optimal. As you would expect, if you go parallel to those lines, you're going to have a much better result in terms of stresses if we analyze those than if you went perpendicular. So we know that no matter what you do by transferring tissues inherent in that, there's going to be stress at the base of the flap. The stress is going to be focused at the distal end of the flap. That's why we get distal end necrosis, as well as sides, depending on what kind of a flap we designed. And the profiles of that stress is highly sensitive to the orientation of our lines of relaxed skin tension. So can we now improve tissue expander placement and also optimize tissue growth. And here is one of the children, again, who had a forehead and scalp nevus that we showed you earlier. So this, again, is all Adrian. We're able to expand the tissues and look through stereoscopic imaging and then isogeometric analysis mathematically to see where are the strains on that tissue. And so if we took that same child and look at the strains, we know by definition at the apex of the expanders we're going to have in red the most strain. So our goal is that using that computational modeling, we can account for patient-specific geometries in the surgical planning to minimize stresses, accelerate healing, minimize scarring, because we tell the families there's going to be a scar at the junction of our advancement planes, but we don't tell them that that scar could be as wide as what we started with if that dehisces or we have some untoward healing complications. So then the next question is, can we take that beyond our ability? If we do it in humans, we can just observe. We can't really intervene. So if we then take that to an animal model, can we somehow ask that question to distinguish when we're expanding how much of that is stretch and how much of that is growth? And how do the biomechanical forces affect that biologic response, both through architectural changes in the tissues and through gene profiling within those tissues? So we have started developing the model. We're looking at the gene sequence of the expanded tissues as well as the stress and strain profiles of the expanded tissues and the biologic histologic architecture of those tissues. And our goal would be to create mathematical models that will help not only the pediatric patient but the breast reconstruction patient who is going to need expanders followed by exchange of implants. So we started with a pig model and put in expanders in different areas and expanded them at different rates and to different fills. And we were able, by tattooing these expanders before and after the expansion process and following them with this multi-view stereoscopy, we can then give that information to the engineers and they can tell us how much stress is taking place on those tissues based on comparison to the baseline. And we then are able to take that, triangulate the data, and then come up with the analysis. And we can then look at that analysis and measure deformation, which is more stretch, versus growth, and look where on the tissues that's happening and does it vary in different parts of the animal. As we refine that process, then we can see, as you can see, the more yellow is the higher stress areas. As we refine that, we can see that both in vivo, and when we take it down, initially we were not getting that same response. We were analyzing it after harvesting the tissue. Then we realized that the tissues flatten out right away, so we have to maintain that configuration, and we can now do them ex vivo. So we know that tissues taken from different points on expanded skin are subject to unequal forces that we couldn't previously measure. We know that the maximal stretch, as we would think intuitively, is at the center of the expander. And then the question is the stretch progressively decreasing further from the center, or is there some relationship to the geometry of the expander and the geometry of the tissues we're placing it in? So that we can look at collagen architecture in those tissues to see how the tissues are responding in different areas. And we know that highly stretched areas are going to have a more irregular collagen architecture. We can look at epidermal thickness. We know that growth is going to give increased epidermal thickness, whereas stretch is going to drop that epidermal thickness until growth takes place. And we can look at cell proliferation through the Ki-67 stains, as well as vascular density in those tissues. And so the collagen structure, as we've mentioned, if you look over time from the beginning throughout, it'll start very, very disorganized at 1 hour or 24 hours. As actually as you get to a certain period, and it relates to the rate of expansion and the amount of expansion, that collagen architecture will start restoring back to a more organized structure. So as we know, we're at the conclusion that growth and stretch are separate entities in expansion. As the time of expansion increases, growth increases and stretch decreases, and the typical histologic changes of expansion vary throughout the expanded area. So with stretch, there's a loss of collagen organization, whereas growth, there's a restoration of that organization and an increase in vascular density. So in conclusion, just using this model in mini pigs, it's a model where we can look at these differential aspects of expansion and try to take that back to the cellular and gene regulation of expanded skin. So that our hope would be that by doing that, we can then say what happens when the skin is not optimal. Can we still recruit more skin? Because that becomes the clinical scenario in someone who's had radiation after breast reconstruction and still being expanded. And our biostatistician from University of Milwaukee, who helps us with the analysis of the gene profiling, because when you get the genes back, there are thousands of genes, and he can then help us to look at those genes that are upregulated and downregulated and distinguish them from the apex of the expander versus the side versus the base. And we can then identify certain ones that are highly upregulated at the apex, like MMP, and those that are actually even downregulated. So that our clinical applications, as we had mentioned, it would go beyond pediatric. It would go to a much larger, really, patient population, which is breast reconstruction. And in the future, it could potentially go not only to tissue expansion, but any kind of tissue transfer, because everything we do where we transfer tissue as plastic surgeons puts stress on tissues, which is why our outcomes are always less than predictable. So in conclusion, we think it will be a powerful tool for surgical planning. We hope to continue to work on these and have predictive models based on these data. And over time, we could, again, this will be more Adrian than us, but that collaboration is what's going to help. We're hoping that we could have a surgical simulator that will tell us how to plan these events prior to actually embarking on them. And so a corollary study that we're doing is looking at not expanded tissues, but transferred tissues, which we do more frequently in the general population, and how should we best transfer those tissues to avoid breakdown. Our goal, again, is to correlate the pig model with the human model to look at those responses in compromised tissue beds, such as post-radiation, and look at mechanisms to protect those tissues in those compromised beds. The biology of tissue expansion then can help us with surgical simulation, and it can help us to improve outcomes in both expansion and transfer. So I want to thank the people who've worked with me. Lindsay is here, not all of my residents are here, but they're really the ones doing the work. I'm just trying to make sure that it's going in the direction we want. But if these are people who've worked over time in our craniofacial lab. You can see that they've gotten awards at the Research Council that we're very proud of. These are the people who've worked in the current model where we've been working on the tissue expansion models as well as craniofacial growth in zebrafish. And again, they've gotten 3 curricular awards in the last 4 years. So that's something that we're really proud of, because we can take students who are not yet even in their medical careers and really give them an interest in this type of activity. So how can the next question becomes that question of these people who've gotten the curricular awards. We don't even know if, first of all, they're going to go to medicine, because they're not all in medical school yet. A lot of them are undergraduates. And how can we bring them into pediatric plastic surgery, retain that interest for their fellowship, and retain it over their careers? And that's the question or the challenge, because the selection of plastic surgery subspecialties is often based on economic factors. And if we did that, pediatric plastic surgery by definition would be an unlikely choice. So how are we going to evaluate the importance of mentorship in shaping and retaining the career of pediatric plastic surgeons? So the first thing is, how can we grow and retain that talent? So we know we have to provide role models for the aspiring residents. We have to provide the mentorship of those residents who express interest in pediatric plastic surgery as a career focus. So why do let's step back from pediatric plastic surgery and just take plastic surgery in general, because that's the category that we are all evaluated in. Why do people choose that as a career? So I was just considering that things, certainly economic gain is something they're looking for. Service to humanity, we like to say they're looking for. Patient needs, no matter what our specialty is, we like to correct deformities. We want to improve appearance, and our goal by improving appearance is that we'll improve social acceptance. We often have, from early in our careers, or I'm sure even the children or the young college students who came to us for the curricular award, have affinities to particular patient populations, whether it be burn victims, children, but there's some affinity that's driving us to say, can we help that population? Camaraderie, no matter where we go in any field, if we do well at it, we'll develop the camaraderie that we have here, and mentorship. So then let's just ask the question, if we know that all those things are positive for plastic surgery, it might be for many careers, why would they choose pediatric plastic surgery over cosmetic plastic surgery? Because we know that the statistics show us that the majority are going to take the first column and not the second. So let's just ask, what are they really looking for? Economic gain, I would say a double plus for cosmetic. Most likely they're not going to put a double plus in the pediatric column. Service to humanity, I would put a question mark in the cosmetic, and I'd put a double plus in the pediatric. Now these are subjective from my point of view, and certainly it's debatable, but I'm just thinking of my impression. The patient needs in terms of correction of a deformity. Let's take life-threatening deformities. It's unlikely that cosmetic is going to be life-threatening. But pediatric, yes, there are cases we do that are life-threatening, airway and Pierrot-Ben, airway in so many infants, so I put a single plus there. Correction of deformities that are not life-threatening, again, by cosmetic, you're taking a normal part and making it look differently. So that's really not a deformity. Again, people can argue what they want to do, but I'd put a plus under pediatric plastic surgery. Improved appearance, certainly both are looking for that. Social acceptance, if it's life or career defining, in all likelihood, pediatric plastic surgery would be no question a plus. Unless you're a movie star, it's probably going to be a question mark for cosmetic. And self-perception, no matter what we do, and that's what the cosmetic people always say, it makes me feel, look like I feel 20 years younger, so I'll put a plus for both of those. Then what about affinity to a patient population? I'm not saying affinity because that's where I'm going to get my revenue from. Affinity because that's what I had a long-term commitment to serve. So cosmetic, it's unlikely that a young 10-year-old said, I have a long-term commitment to see these ladies have a different figure. But it could be very likely that a 10-year-old says, I want to help other 10-year-olds who might have some problems in social acceptance if we did not address that. Camaraderie, again, no matter what specialty we go into, we'll develop the type of camaraderie that we have in this room if we are amiable. Mentorship, and I'm trying to distinguish, if it's mentor-initiated, meaning the mentor goes out and seeks the trainee and says, I want you to come into my field. In all likelihood, cosmetic is not that field. You're not having your cosmetic guy on Park Avenue running out to the resident and say, come join me, unless he's a superstar to begin with. But this is why I put a double plus for pediatric, and I put it in red, because that's going to be the topic of my next set of slides, is mentor-initiated recruitment is the focus in pediatric plastic surgery that makes us unique in that component. Mentee-initiated, it could be self-serving or not self-serving. I would say that the mentee-initiated in cosmetic, they're most likely going to run after the guy in Park Avenue because they know he's going to help them become their partner. But in pediatric plastic surgery, it's also going to be mentee-initiated, but not necessarily be the partner of that person. It's not always self-serving. So let's just ask, given that information, and you can agree or disagree, but it's just a way of looking at our specialty, what are we doing? What are the plastic surgeons doing? Let's look, Don has been chair of the American board, so this is the latest data. How many of those modules that we have been using for maintenance of certification went in what we might call pediatric plastic surgery or a subset? So if you add up a cleft palate, non-syndromic craniosynostosis, unilateral cleft lip repair, secondary cleft nasal deformity, it comes to less than 4% of those tracers. So that if you add up breast, it comes to almost 50%. So just realizing that we are at a disadvantage in terms of numbers, at least that's just from certification data. Now let's look at what people call themselves. So this is from the most recent ASPS survey of our membership. How do they describe themselves? So if the majority certainly are going to be describing themselves as aesthetic or cosmetic, hand, microsurgery, reconstructive surgery, but even reconstructive, only 16% are saying craniofacial. There's not a separate category by the ASPS to say pediatric, so I'd call that to fall under craniofacial. So we're still, if you look at those categories, only above regenerative surgery, and I don't really even know what regenerative surgery is. So this is where I'm going to focus this last part of my talk, and that is mentorship. Really the future of our specialty, those two double red pluses that I put in there, because that's what is, in my view, recruiting and retaining our talent. And this is from the Ramayana. This is Valmiki, the great mentor in Indian epic religious texts, and those two young boys there are special boys. They are Love and Kush. They are the children of Lord Ram. So and they had to grow up without Lord Ram being there. The story, I'm not going to relate the whole thing, but you just need to know that their father, who was one of our greatest heroes of all time, could not be with them for social circumstances and things that we might not agree with. But regardless, they were raised by their mentor, at least not raised by, but taught by their mentor, and they became some of the greatest figures in our epic mythology. So the question to mentors and mentees that I asked, and I then surveyed our greatest mentors in pediatric plastic surgery, craniofacial surgery, and fortunately they were all very enthusiastic to work with me on this project. So I asked, tell me an event or series of events with a particular mentor that helped to direct you towards a career focused in craniofacial or pediatric plastic surgery. What advice would you give to encourage the current residents and fellows to pursue that career? And what methods have you found to be the most effective in directing residents and fellows towards stable, long-term careers in that specialty? So starting with the various individuals, and here I'm going to take the liberty of reading sections of what they said, because each one sent me like 3 or 4 pages, and I can't read all that to you, so I summarized what I thought. But starting with Ron Zucker, one of our great mentors in pediatric plastic surgery, is what was the personal event? My greatest mentor was Ralph Mangtolo, with whom I worked as a resident and then as a surgical partner for decades. We'd bounce ideas back and forth and come up with innovative solutions for major problems in head and neck cancer reconstruction, upper extremity muscle loss, and of course facial paralysis. Working together allowed us to do what we did. Otherwise, it would have been impossible. His advice to residents and fellows: don't spread yourselves too thin over multiple areas. Rather, focus on a couple of areas that they have a passion for, that perhaps are not too common and that they can become an expert in. In this way, you can advance the field, which is enormously satisfying, and get to know the people and families affected by their area of expertise. Personal conversations that specifically analyze a patient problem are the best way to stimulate interaction. As doctors, we must never forget that it's the patient that comes first and should be our ultimate focus. What are your teaching methods? It's extremely important that a young surgeon have support from older, respected colleagues. I can think of so many avenues I may have taken if I would have had the right support and guidance. It's gratifying to see that our trainees take the information that we've given them and take it one step further and advance the field one step further than you have taught them. That is a true measure of success, that we have not just transmitted our knowledge, but also stimulated our trainees to take that knowledge further. And we're certainly glad that even though Ron didn't have the mentors he might have had, that he chose pediatric plastic surgery. Some of his mentees, and I've asked, as again with each mentor, I've asked one of their mentees to give me the reciprocal view, and I see that Allison made it. She was caught in traffic. Thank you, Allison, for getting here. So what was a personal event? I was somewhat concerned that I was applying for the wrong fellowship match. I'd applied to craniofacial, but I was torn that my interests and strengths might have been more aligned with microsurgery. But I knew I wanted to work with children. During my first visit with Dr. Zucker, he and Greg Borchell were called urgently out of the meeting to assist with a cardiac bypass procedure on an infant. I knew then that pediatric microsurgery was the perfect fit for me and had a broader role than I realized. Ron Zucker provided me with the courage and capacity to follow my passion to practice pediatric plastic surgery. He's the ultimate example that passion can provide a successful and rewarding career. While others may measure success only in dollars, Ron reaps the many rewards of a pediatric plastic surgery practice daily. Emulating his optimism and relaxed attitude is something I continue to strive for in both my professional and personal lives. Advice to residents and fellows: be honest with yourself about what your passion is. If you're inspired by your work, you'll excel and ultimately make a bigger contribution. Teaching methods. One-on-one talks and engagement and continuity of a child's care have been the most effective. Many residents are enticed by interesting cases, but the bigger picture needs to attract residents for the longer commitment. And those are two of Ron's mentees, Greg Purcell and Allison. John Mulligan. Advice to residents and fellows. Don't assume they'll take a pediatric plastic surgery position and be given new cleft and craniofacial patients. I remind them, if working in an established unit, to be patient. They're likely to be experienced senior surgeons on staff. Maybe consider developing expertise in another or new field, and that's what we've all done for so many. That's kept us innovative. I also suggest that once they find their dream job, stay in place and don't wander. They have an obligation to stay with their patient, and certainly John did that through his career. Teaching methods. I never thought of myself as an inspiration or a role model while working closely with fellows in the clinic or 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 writing papers. It's just great fun. Aaron Green, who you all know so well. He was a mentee by Dr. Milliken. Personal event. My youngest brother was born with a cleft lip and palate and suffered ridicule because of his appearance growing up. He's the reason I wanted to become a pediatric plastic surgeon. Visit to Dr. Mulliken during my 4th year of medical school. I saw patients with vascular anomalies for the first time and thought that they were a much worse problem than my brother's condition, which is how I became focused on vascular anomaly. Dr. Mulliken then introduced me to Judah Folkman, who you just heard about from Dr. Habal, who subsequently offered me a position in his lab. Advice to residents and fellows. Choose the area that they're most passionate about, which will help them innovate and stay in the field. I try to tell them that it is more important to do what you're passionate about than where you live and how much money you make. I also encourage them that they will find a job in pediatric plastic surgery after their fellowship. Teaching methods. Exposure to pediatric plastic surgery is the best method to attract people to the field. That is, giving lectures to medical students and showing passion for the field to our own residents. Mentoring from a pediatric plastic surgeon is critically important. Linton Whitaker. Personal events. Recognizing the potential to be involved in a new and extraordinary field as a result of being at Tessier's presentation in Montreal in 1971. I had a dominant interest in the human face and realized we had multiple patients at CHOP that would benefit from this new undertaking. Advice to residents and fellows. Be brutally honest about your results. See the connection between facial aesthetic surgery and craniofacial surgery to make the result normal, or where possible, ideal normal. Careful and long-term follow-up, including the entire growth curve where appropriate, of your patients to see the real end result. Teaching method. Repeatedly conveying the endless fascination with the problems and the unending effort to solve the insoluble problems. Always strive for perfection, even while recognizing it will never happen. Now, many of you in this room are mentees, so I could have chosen any of you really, but I chose Scott Bartlett. Personal event. I always had an interest in head and neck. Jim May was one that directed me to craniofacial surgery. I realized that you can't do this sort of surgery unless you're in a pediatric-focused institution, hence my decision to stay at CHOP through my career. Advice to residents and fellows. Be willing to do the broad spectrum of types of cases, lots of lumps and bumps. Craniofacial practices that are robust are few and far between. So you have to be willing to put in the time doing the menial things that you may not have wanted to do, but are necessary as you build a pediatric practice. Look at the institution and the geography. We're in a period of consolidation in healthcare. Be willing to stick it out and support that institution. Adult practice is not incompatible, particularly if it utilizes techniques derived from the pediatric population. This may help to supplement income for pediatric plastic surgeons. And teaching method. The most productive times are in the OR where you can show them new procedures and approaches that will pique their interest. They often are so attuned to mainstream plastic surgery, breast and aesthetic, and they haven't even considered pediatrics. And I just want to point out, I know Steve was already talking in that picture, but he probably recognized himself. But there are others besides Steve. There's, you see Linton, you see Steve, you see Jeff Fearon to Linton's left, or Linton's right. You see Scott Bartlett, of course, Kent Lynn, Mike Uremchek on the far right on my side. That's young Jack Yu. So a lot of you guys are there. But Yeah, well, and there are others there, but you just show that I could have chosen any of you to do this, but I can't be reporting for the rest of the day. Ken Salyer, personal event, exposure to Paul Tessier. Through Dr. Tessier, developing friendships with Linton Whitaker, Ian Monroe, Dan Marshak, and Fernando Ortiz Monasterio. Advice to residents and fellows. One should really focus on this subspecialty. No longer can a single individual deliver state-of-the-art care. It requires collaboration. Be a pediatric plastic surgeon. Don't feel that you have to do cosmetic surgery to make a living. Take the active role in development of this specialty. Minimize drift to other specialties. Adult practice should not consume one's identity, but the application of craniofacial principle to adults is acceptable. Teaching methods. Excellence of surgery and focus on the outcomes. Follow your patients over time so you can see the consequence of your surgery, particularly with the added dimension of growth. Remain flexible and open when considering techniques so that one continues to improve in techniques and outcomes. Mentee number 1, Henry Vasquez. Personal events. The three that come to mind are Josh Yurkiewicz, Ken Salyer, and Louis Vasquez. With Dr. Yurkiewicz, who you see down on the lower left, my aspiration was to obtain his wisdom and his sense of compassion and discretion. With Ken Salyer, it was to learn his abilities and techniques and also his charisma and dealing with patients and fellow colleagues. In the case of Louis Vasquez, he has been able to put together all these essential elements of being a doctor and a humanist. He has been able to establish priorities, namely patient care and care of your fellow man, decency towards all, ethical behavior, and love of family. Henry, thanks for saying that, and I think you said it beautifully. Teaching methods. Mentoring is best accomplished by example. I've tried to emulate and imbue this in students and residents in order to inspire them and move them forward with curiosity and dedication. I've ascribed great importance to mentorship meetings among the residents. They're meetings without grades or evaluation, but rather to talk about what's going on in the life of a resident. In this way, I can get to better see their life experience and they can see that I'm interested in their well-being. Second mentor, and one reason I chose this is because Dr. Salyer said if he had to take one of his mentees and who has had the greatest impact on their career, he would say it was Dr. Yamada. Personal event. I was particularly fascinated by the article, Personal Contribution to Craniofacial Surgery by Ken Salyer. Many questions arose. How can he achieve these excellent outcomes? What are the differences between pre-op faces and post-op faces? What makes attractive faces? Advice to residents and fellows. Keep thinking about what is normal and what is abnormal. Read major papers from Tessier to the present. Teaching methods. Show how much I love my work as the resident is observing my activities. Discuss preoperative planning in detail prior to the surgery. Explain my current thinking or philosophy and why I'm doing this particular procedure, and explain what is achieved so far and what is still unsolved. Bauman Gairan. You may not recognize him as well, but of course you recognize Tessier. This was quite a while ago. Personal event. Listening to one of Paul Tessier's lectures, I was intrigued and inspired by how he could change the quality of life for facially deformed patients. However, my most treasured mentors were my patients. By listening to them, I learned what works and what does not, and they helped me to discover new ways of serving them. Advice to residents and fellows. Whether or not they're going to be a full-time craniofacial surgeon, a craniofacial surgery experience is going to be colossally helpful. After correction of a major hypertelorism, they'll not see any boundaries in head and neck surgery. Emboldened with this experience, they will more likely become an innovator. Application of craniofacial principles to the adult population led me towards innovation in rhinoplasty and migraine surgery. These principles can be of tremendous value in extending the applications of craniofacial surgery from children to adults. And certainly we know that Bauman has been the world innovator in those areas. Taking one of his mentees, Ali Tatanchi. Ali, thanks for coming. Personal event. The positive feedback from patients and outcomes from secondary and tertiary cases done by Dr. Garan, which did not get the best results by previous providers. Teaching methods. Being involved in patient care, especially in the OR, made me more attached to the specialty. Dr. McCarthy, who's been a mentor for me and again, so many others as well. Personal event. John Converse. He loved research, loved surgery, intellectually driven, a good leader. Converse was the total package, particularly in the 1970s. I would often do things with him in mind, consciously or subconsciously. In 1971, Tessier came to NYU and operated with Converse. The excitement of these events was the first time I was really excited about surgery. Evolution of thinking that Tessier's techniques could be applied to the pediatric population opened an unmet niche in surgery. His advice to residents and fellows: follow your interests. What appeals to you? Follow mentors who are enthusiastic teachers. Do not focus on lifestyle or salary from early career, but ask residents what they want to be doing at age 50. Follow-up is a boon for pediatric plastic surgical practices because patients can be followed as they grow up. I've had relationship with patients 47 years later. Teaching methods. The most important method is to set an example in both one's private and professional lives. Leadership by example is how I live my life, and I, having been with him for so long, would say that that's absolutely true. The mentor-mentee relationship is a two-way street. Both must give to it. The mentee must give back. There must be feedback. The mentee must challenge the mentor. Example, rounds at Bellevue, when the residents first showed me the Elizarov device. We both learned from one another, and craniofacial distraction was born. And that was born out of mentorship, a reciprocal mentorship. Richard Hopper, his mentee. Personal event. During the last year of my residency, the craniofacial cases unsettled me. Their high complexity, their potential risks, and how in many cases the surgeon wished they could have done more. I knew it was a journey on which I would never get bored. Dr. McCarthy was my mentor at NYU. His mentorship was active and direct. He constantly challenged me to think outside the box, to be tenacious and adventurous as a surgeon and academician, and to hold myself to a high standard. He took the enthusiasm I had from my Toronto mentors and crafted it into the focus and dedication I needed to succeed in academic surgery. Most importantly, he has remained a guiding presence in my professional life, and that I want to emphasize because the mentorship doesn't stop when we finish our training. And teaching methods, and Richard was honest, my job now is to learn how to emulate these mentors and pass this on to the next generation. So I just want to say a few words in closing about my personal mentorship as a pediatric plastic surgeon. As I've told you already, Dr. McCarthy is a super mentor. He was with me from when this young man was 2 years old to this young man now, and I'll show you that he's still with me. But that's when we were in fellowship. When I got my new job, the very first year, the first visiting professor we had was Dr. McCarthy. And that, if any of you in training can do that, have your mentor come to your institution. It reinforces your role in the institution. The people who are above you, because you're the young whippersnapper, they see that you're being supported by someone that they respect. It goes a long way. And just to know how long that's come, if you look at the young resident or fellow to Dr. McCarthy's right, that is Steve Bonowitz, who is now the program director in New Jersey. So people have come a long way since then. The other thing that happened during all this time is these two young people in this front row went from here. We found them just sort of wandering around in India, and we took pictures of them. And then we came back 10 years later to see what they were doing, and there they were, doing the same thing. They just grow up a little bit. And they went on then to become, one became an adventurer, one becomes an aspiring movie star. So to recognize that, that's all part of our mentorship, and it's all due to my wife, Smita, who did all the mentorship. She's here as well, but that's where the mentorship came from. It didn't come from me. I was really the financial supporter of it all. But to go through all of that, to show that mentorship relationship doesn't end. Dr. McCarthy at his retirement function at NYU, a lot of you all went back with me for that, but that was him and Carlin, his wife. Dr. Gairan, as you know, a tremendous innovator. What he said in his words to me was absolutely true. It was that ability to take our craniofacial principles to the adult population that's made him the world leader in rhinoplasty, the world initiator of surgical migraine surgery. So clearly he is an innovator. In this case, we were designing for our craniopagus twins how to do tissue expansion, which I already talked to you about. How can we plan it so we get enough tissue that after we separate the twins, we'll have that? Because if you were there at the session yesterday, when Dr. Salyer McCarthy and Kawamoto were there talking about craniophagus twins, Dr. Kawamoto said their one shortfall was they didn't anticipate the amount of tissue they would need. So Dr. Garin, with his innovation, was looking at a model stereolithographic way of figuring that out. Ken Salyer, those of you who know him, is certainly a mentor to Henry, a mentor to Akira Yamada, a mentor to so many, but certainly a friend to me, and that has been important. And so those super mentors, what was said earlier is maintaining that mentorship over time. Here it was yesterday, Dr. McCarthy with me and Ken Salyer with the mentee that he feels he most impacted, Akira Yamada. And then if we also have to think of ourselves as mentors to our patients. Here's a little 3-year-old girl when she came from China, and here she was when she came back for a minor lip revision at age 9 years old. But they really value that time back, and they traveled all this way across the country. It's a special thing for them because as they're traveling, they're just remembering, I'm going to meet my doctor. So you are an example to them. So in conclusion, mentorship is really the key, in my view, to recruiting and retaining our specialty. It provides role models for aspiring residents, following up with proper mentorship of those residents as they develop a career focus, retaining that relationship with mentors as their careers develop, and developing reciprocal mentorship relations as careers evolve. And I put that in italics because all of you are in that position right now, that what brought you here into this room, it's what's going to bring the next generation. Lindsay is sitting there keeping an eye on what she does after this. But it's going to bring that next generation to be standing at this podium in a couple of years. And we're here because of the personal time and investment and inspiration that our mentors gave us. We're going to drive that generation, pay it forward, seek to serve as a mentor. Remember what I said, double plus in red. It's got to be proactive mentee and maintain continuity. Again, many of our great mentors have said minimize your career moves if at all possible, but maintain that relationship with your mentor. And I want to finish to say, as we drive that innovation, again, it's not that everything happened in India, but a lot of it did happen in India. Here is here's Sushruta, and if you look at this was at the hospital in Kochi right outside, but if you look at his accomplishments in terms of driving plastic surgery forward, this was about 500 years before Christ. It's unbelievable. So that there is innovation. Whether we can maintain that innovation is a second question, but we can certainly foster that innovation. Thank you. I just want to emphasize, the reason I didn't feel as nervous about this talk as I do about others is because it's you guys who put me up here. It's you guys who've done this. It's you guys who are the product of all those people I showed you. So I was just trying to represent them.
So thank you for that inspiring talk. We have about 10 minutes left if people have any questions or comments. And we also have a certificate for Dr. Gosain, which is the Clinician of the Year. So thank you so much. And we have about 10 more minutes for questions.
Arun, that's very nice lecture. For us, the older folks, make us go through history. Very well presented.
Well, it's the one area where, again, we all get emotional when we talk about our families, but as I talk about these people who brought me here, I get just as emotional. So that's something, I don't know if you perceive that, but it really is something close to us.
Arun, I had a question for you. So what do you tell people today, right? So every day we're here, people all say, well, I'm not going into pediatric plastic surgery, craniofacial surgery. There's no jobs. I mean, I remember hearing that in 2002. I'm sure, Buck, you heard it a lot before me and everyone else. What do you tell people now?
Yes, I think I'm just going to summarize what I heard from these great mentor-mentee relationships. That, as Scott Bartlett said, you've got to be ready to diversify when you begin. Your practices might become more specific over time, but you can't go in there saying, I'm a craniofacial surgeon. You've got to go in there and say, I'm a pediatric plastic surgeon. If you look at pediatric plastic surgery, it covers the waterfront. The most hospitals don't have enough pediatric plastic surgeons, they have enough craniofacial surgeons. But if you're willing to do the things that you didn't do, for all this tissue expansion that I did in Milwaukee, wasn't because they wanted a tissue expanding surgeon. It just so happened that was a waterfront that had not been covered. So it's always there at the children's hospitals. You just have to look for it and do it.
All right, great, thanks so much for that. All right, so that concludes the breakfast, and we'll look forward to seeing everyone next year.